Good morning, everyone. Thank you for being here today. My name is Vivian Singletary, and I'm the Executive Director for the Public Health Informatics Institute. We're based in Decatur, Georgia. And today I am hosting this dynamic panel discussion on global and domestic surveillance. Joining me on stage, I'm going to start with Caitlin Rivers, and she's the Associate Director at Center for Forecasting and Outbreak Analytics at the Centers for Disease Control. And also Janet Hamilton, she's the Executive Director at the Council of State and Territorial Epidemiologists. And last but not least, Eric Blank. He's a Senior Advisor for Public Health Systems at the Association of Public Health Laboratories. So before we get started, I want us to set the stage and give each one of our panelists about a minute to let us know about their role in surveillance during the pandemic and their role now. So I'm going to start with Caitlin to answer that question to get us started.
Thank you. I've had a few different roles over the course of the pandemic, given that it's now been 2+ years. I started as an academic at the Center for Health Security. At the Center for Health Security, we work always on epidemics, pandemics, and deliberately occurring events, and have been doing so going back 20+ years. I then had the opportunity to work for about 5 months on the Biden-Harris presidential transition team, where I focused on issues around testing and schools, which are of great relevance to surveillance. And I am now on the founding leadership team of the Center for Forecasting and Outbreak Analytics at CDC. And of course, the quality, quantity, and timeliness of surveillance data is of great interest to us because we need all of that to do our best work.
Thank you. Janet?
Great. Thank you so much. It's wonderful to be here, and just want to echo my appreciation for the Academies for convening this. As Vivian mentioned, I'm Janet Hamilton, and I'm the Executive Director of CSTE, or the Council of State and Territorial Epidemiologists. And we were founded in the 1950s by Alexander Langmuir, who you heard Dr. Ali Khan mentioned, also was the founder of the Epidemic Intelligence Service. And we are a nonprofit, and we convene the 50 states, the territories, as well as represent epidemiologists working at the local and tribal level to essentially help, what can I say, with communications, lessons learned, policy settings, and also work very integrally with the CDC in terms of helping all of us in this major public health system of systems work well together.
Thank you, Janet. Eric?
Thank you very much, and thank you for the invitation to be here. The Association of Public Health Laboratories represents the governmental public health laboratories in the U.S. We think of public health broadly, so it's not necessarily the public health laboratories that have been at the center of the COVID response. We also represent governmental environmental health laboratories, governmental food laboratories as well. From the standpoint of COVID, much like our colleagues, we work to coordinate the efforts of our members with the federal response, both at CDC and FDA. We also work very closely with our public health partners, particularly CSTE, on issues such as reporting, surveillance, and surveillance processes, as well as ASTO and NACHO.
Thank you, Eric. So thank you all for setting the stage. So let's dive into this dynamic discussion. So it's December 2019. Describe the state of domestic and global surveillance. I'm going to start with Janet on this one.
Thanks, Vivian. Not something you can answer in just a couple of minutes, but what I'll say is, I think we can probably all remember where we were during those early case identifications. And I think our global and domestic surveillance within the United States was really set up for handling small events that epidemiologists really could quantify well when there were about 20 to 50 cases or so, and you could almost do that, with the work that you were doing every day to keep up with all of those details. I would also say, though, we had made a number of investments to start to think about how we could really move data across our public health system from the local, states to federal level, but really a patchwork. Some states had done that much better than others, and we had major gaps of delivering the right level of actionable information onto the federal government to really think about how to manage a response. I think some great progress had been made in the space of electronic laboratory reporting for the labs, that had been doing that for a long time. And we had also made great progress with some of our case-based disease surveillance systems and thinking about the needs, but not necessarily being able to fully implement them and deliver the right level of data at the right time for the right level of actions to occur.
Thank you for that insight, Janet. I'm going to jump over to Eric and give you the floor to answer that question.
I think Janet put it very well in terms of the overall system. I think one of the things that struck me in those very early days is we have some fairly well-defined surveillance systems, even looking for novel or emerging threats. And I think of the influenza surveillance system that both is in the country and worldwide. But the point is, they're very siloed. They are for influenza. They're for novel influenzas. When you think of the last two public health emergencies involving an infectious agent in the U.S., nobody was looking at Zika. Some of us had heard about Zika, but nobody was really looking for it as an emerging threat, and certainly nobody had coronavirus on their radar screen. And so we had things in place, but they certainly weren't broad enough to catch what was emerging. And when we did see something emerging, in effect, we were so focused on what was going on in China, we really didn't think about what might be coming around the other way. And as we noticed, probably that summer of 2020, as some of the sequencing was going on, the U.S. probably received its biggest dose in 2020 on people coming from Europe into the U.S. that had been exposed in Asia. They weren't coming from the repatriated citizens in Wuhan. They were not coming from the cruise ships that had been over in Asia. So we had some systems, as I said, they aren't broad enough. They aren't a big enough net to see what all is emerging. But also, I think we didn't use them very wisely for a number of different reasons, some within the control of public health and some not so much in the control of public health. I don't want to stick my neck out too far, but I think we have a framework. I am a little leery of people who think we can in some way predict what might be the next emerging threat. But I think we have a framework for at least broadening the net to perhaps do a little bit better, at least see what might be coming not in a specific organism, but what may be coming in terms of the type of organism.
Thank you. I'm going to go over to you, Caitlin.
Thanks. Yeah, when I look across the last 2+ years of the pandemic, I see a lot of highs and lows with surveillance, and I think that's the story of public health generally. There is no single area where we can predictably excel, and there's also no single area that we have not been able to make immense progress on over the course of the pandemic. So I think the detection of the first cluster in Wuhan actually happened much faster than I would have expected. The world was made aware of this cluster when there was just 30 some odd cases, and it was within a week or two of what we currently understand to be the emergence event. And I think that's pretty impressive. And shortly thereafter, the genome was published online and shared for the globe to see. Both of those, I think, are enormous strengths. Detection in other countries, in other locations, I think varied from place to place and had great bearing on how surveillance went from there on after. In the United States, we struggled to understand where the disease was circulating early on in the pandemic, but I think it is important to recognize that we've made enormous strides, enormous advances in being able to track the virus from cases to hospitalizations to deaths. I wanted to highlight three particular innovations, or at least innovations that have really gained a foothold during the course of the pandemic related to surveillance. The first is genomic surveillance. The genomic surveillance infrastructure was thin when the pandemic started, but I think that through sustained investment and through amazing collaborations with federal partners, state partners, lab partners, academic partners, we now have a genomic surveillance system that we can be proud of. And I think that that is a lesson and a system that we carry forward even after this pandemic has waned. At-home testing, I think, is an important advance, and I think that's another one that will stick around. At-home testing has, of course, been available for other diseases, but not like we're using it now. I think that consumers will grow to expect that they will be able to definitively diagnose, as we heard from Dr. Brooks earlier, what is happening with them for conditions that may not require medical care. And I think we can use that information to make better decisions in our lives. The challenge, of course, will be translating that into public health data because we don't have visibility on what's happening at home. But in my personal opinion, I think that's a trade-off worth making, and I think it's something that we can grow to be able to work around. And the third and last innovation I want to highlight is around wastewater testing. I think we're still learning how best to implement that, how to bring it to scale, how to use it in public health practice. But I think particularly in this moment in the pandemic where we're losing visibility on cases, wastewater is really filling that gap and helping us to understand what's happening in communities. And I think we're going to find more and more ways to use that wisely.
So Vivian, I think I want to go back to the question that you posed, which is where were we in December 2019?
Yeah.
And that, I mean, I do think it's important for people to really digest what that was like. I mean, for a health department that was going to be receiving information about these individuals that, you know, were potentially infected with a new and unknown agent, that was going to happen via a phone call from an astute clinician who said, I've heard about this on the news. I think I have something unusual. I want to talk to the health department about this. And I think that is always going to be a foundational component, and we should never forget how important that is. But then it's what happens after that. So early in this pandemic response, you know, we were very closely assessing who could even get a test. So we had a number of health departments that had identified something unusual, but we were not actually offering a test for that individual. And there were bottlenecks already from day one, which, you know, happened during Zika, it happened during H1N1, that we were quickly overwhelmed with being able to triage an unusual person to a laboratory collection site, to that sample getting to the right place to get tested. And I think that still exists today. If we had an unusual event today, we would still have that critical problem. The other thing that's true is as soon as we were sort of dealing with these unusual cases, then it's how do we start to triage volumes of calls and volumes of unusual information? And again, a lot of that information was coming in via phone calls and faxes. And the initial tests that were happening in different sectors outside of the state public health lab, not all of those laboratories, once testing was available, were hooked up and online to be able to deliver the information to public health. And then volumes of information started to come in. And once we had volumes of information, we were not set up to rapidly process that, turn it around, and deliver the right levels of answers to decision makers. And I really think just trying to think back to those early events. I mean, we're in a pandemic now, and we probably need to be having two types of discussions. Not what are we doing for the next pandemic, but what are we doing today? Because the situation has evolved and it's not the same. And the American public does not view it in the same way, and we don't have the same limitations in some ways. I mean, we actually have control measures available, but how do we talk about them in ways that actually lead to behavior change? And then I think we also really need to look critically at those events that start and how they quickly and rapidly change, and what we're going to do in those types of key situations going forward. And I'll just say, you know, from a disease surveillance perspective, it's easy to talk about data like a monolith, but data means a lot of things to a lot of different people. And it's really important that we look at the questions that we want to ask, and are our systems collecting that information in a way that's going to deliver the answers in near real time. And so, you know, Vivian, I think trying to think back, if we're early in the pandemic versus now, it is a really different kind of situation, and the way that maybe we need to handle it is different too.
Yeah, I appreciate that insight. And actually, it's a question that I want to, you know, open up for our other panelists too. And it's really about how has COVID-19 impacted or changed our domestic and global surveillance, and where do we see it going, or where do we need it to go in the next 5 to 10 years? And I like the discussion in our previous panel when they were talking about the boom and bust cycle for funding for public health. So we know that's going to happen along with COVID-19 at some point in time. You know, right now there's a lot of interest in it, and getting ourselves beyond where we are now and prepared. But let's talk about, and I'm going to jump over to Caitlin. If you can tell me what you think, what you predict over the next 5 to 10 years will happen with our surveillance system, and tell me, in your opinion, how things have changed over the last 2 years.
Well, the good news is I think that the recognition that we need high quality, timely public health data is now much more widely recognized than it would have been prior to the start of the pandemic. Never before would I have thought that millions, if not tens of millions, of Americans would get on their phones or watch TV to find out what the local COVID numbers, disease numbers were in their area. But that is the situation that we currently find ourselves in, and I think it's important that we capitalize on it, and use that to build a future where people are paying attention to the public health concerns in their area and using those insights to make decisions in their lives. But I think, of course, we need to make changes in order to get there, to realize that vision. We heard from Janet that many of our public health agencies are using data infrastructure that is decades out of date. And Janet and her organization have been excellent partners in helping to push forward substantial funding for the Data Modernization Initiative, which is going to upgrade state and local public health data infrastructure so that our public health officials can use modern systems and not use fax machines. And so I think that's an important development that will unfold over the next 5 to 10 years. I'm not exactly sure of the timeline, but I think that we need to continue pushing and make sure that this is not a one-time investment. It's a sustained investment in keeping our public health data infrastructure fully operational, because there will be another threat. And you go to war with the army you have, and so we will go to war with the surveillance systems that we have.
Thank you, Caitlin. I want to pose this to you, Eric, and get your thoughts on it.
Sure, thank you. Caitlin referred to the wastewater testing, but this whole aspect of sequencing and the use of sequencing for surveillance really has come to the fore, not simply because the technology is available, but for probably the first time, and certainly in a major event, sequencing is playing a significant role, both in surveillance and obviously in clinical care. APHL actually wears two hats. Our members are laboratories, the public health laboratories, doing the kind of work that's being discussed by the panelists here. But APHL itself also manages the APHL information messaging system, the AIMS platform, one of the platforms named in the CARES Act by which anybody performing a COVID test can report those results both to the jurisdiction in which that entity sits, as well as to the federal government. And so, again, adding to what both Caitlin and Janet said, we're sort of at the forefront of that Data Modernization Act, both in trying to connect with CDC, because CDC does not necessarily, in all of its laboratories, have the ability to do the kind of data transmission that we sort of think about and what COVID has opened for us generally, but also to expand that kind of surveillance and the movement of the information. So the surveillance aspect, to Janet's point, is not just the laboratory test, but it's also the case reporting. And moving those pieces of information to the right places at the right time electronically, I think, is where we will be going and where improvements will be made, which are going to capture the actual physical acts of surveillance, both from a laboratory and from an epidemiological side. So I think where we're going to see the improvements in 5 to 10 years are going to be in those areas of electronic data transmission.
Thank you, Eric. Go ahead, Janet.
Vivian, I just want to say, I think, the next 5 to 10 years can be transformational, but we really need some concrete and strong leadership to say this is critical, and we are going to look systemically at how we bring healthcare and public health together to really move data across the system. Where do we need to make incentive payments into the healthcare system, into a physician's office, to record information in an electronic health record in a meaningful way? Where do we need to assure that that information is able to be seamlessly captured and passed to the state and local level for decision-making purposes? Where is the health department going to be in terms of being able to collect all of that, aggregate it, and make informed decisions for their leadership, as well as for their governmental leadership and for the public, so that the data is presented in meaningful ways? And then how is that information also passed on to the federal government for assistance and leadership in terms of managing the overall resources of the pandemic? And I mean, many of you know I was an epidemiologist for many years in the state of Florida, and it's painful when you don't have the data that you need to make the decisions that you want to make. And it's painful when you're being asked for information and you don't have it, but you know you could have it if the information moved really rapidly into the system. And so I do think it's going to take some really critical diagnoses of these are exactly where we're seeing gaps, and here's how we can alleviate those gaps and really bring healthcare and public health together. I would also just say it's wonderful that we've had an investment in resources to support data modernization efforts, but it is not nearly enough. I mean, we saw within the healthcare sector $40 billion invested in electronic health records, and so far we've seen $1 billion put aside for the public health system in total. $1 billion for a national public health system that delivers data to local decision makers, to the federal decision makers, and to the public. I mean, it is something that I think in 5 to 10 years we could look back and say we didn't do if we don't really have the leadership to move this forward in a really well coordinated way.
Yeah, very, very good points, Janet. You also pointed out something in one of your previous comments about, the two different discussions that we need to have, talking about what we need to do now and what we need to do in the future. And so I want to go back to kind of what we need to do now. And I want to start with Caitlin about What is the biggest challenge with domestic and global surveillance at the moment? So what are the things that we need to immediately address where we are with the pandemic now?
Well, one of my concerns at this moment is that many of the data streams that we rely on at every level of our public health system to make decisions around managing the pandemic are actually tied to the emergency declaration. And when the declaration ends, our visibility on many of those data streams will go away. Data on hospitalizations, data on lab reporting, these are data that we do not normally get at the federal level, that we will lose potentially. We have time to do something about it, but that we could potentially lose when the public health emergency declaration ends. And I think that has enormous bearing on our future ability to manage this pandemic and the future threats that we will face.
Thank you, Caitlin. I'm going to go to you, Eric, to get your thoughts on that.
I think it does go to data. I think to Janet's point, that aspect of getting the data, moving it effectively to where it needs to go to, it's going to be challenging. To Caitlin's point, it has to also be sustainable. It's one thing to say we're going to build a system and spend whatever amount of money it is to build a system. But we have learned the painful lesson on the laboratory side that we can build a nice system today, but if there's not money to sustain it, and it takes a lot of money to sustain a good laboratory information management system and the ability to transmit data, then we'll be talking about this 2 years from now and say, what have we accomplished? So it's a case of not just having the money to build a system, but it's also having the money to sustain and maintain that system going forward for the 5 to 10 years. In my mind, that's the biggest challenge with this.
Thank you. Over to you, Janet.
You know, Vivian, I mean, it's hard to choose the single biggest challenge, but I really feel like the challenge that we have in front of us is that we have not convened public health, healthcare, CMS to really identify these are the questions that we really need to be answering, and how do we effectively leverage each of our collective abilities to ensure that that information is going to be able to move into and across the public health system. And I would love to see something like that happen. I think there is a lot of good, and there is a lot that could be done with some careful care and feeding and the development of a true national surveillance action plan that talks about the different levels of actors and the different types of information that's needed. And I think we are at a juncture where that's been needed for a long time, and I think we need it now.
I think Janet makes some very, very good points. I would go one step further. I know this is a forum about COVID and what happened, but I think that effort needs to be broad enough to cover national surveillance for, any emerging infectious disease threat. We can learn a lot of lessons from COVID, but bear in mind COVID is a highly transmissible respiratory virus with certain characteristics. There are other things out there that will also present a threat. And I would hope that those discussions, if we can have them, can incorporate and think about those other emerging threats beyond, an easily transmissible virus. Thank you.
Thank you. So you guys lead me to my next question. I have a couple more questions before we open up for the audience. So we've talked a lot about what are the things that need to happen now. But as we look forward, I want us to think about the non-negotiables. We have a lot of funding coming in from CDC for data modernization. And when we look at that, I want us to think about what are those kind of non-negotiable critical changes in domestic and global surveillance that we absolutely must make to face future public health emergencies. And I'll start with you, Caitlin, on that one.
Well, I certainly support both of my colleagues here have made excellent points that we need to sit down and figure out what questions we're answering and what data and what systems we need to support those questions. I think sometimes in the broader public health community, there's a sense that more is more when it comes to data, and that may be true, but it shouldn't come at the expense of collecting the data that we actually need to answer the questions that need answering, because sometimes more data doesn't actually get you where you need to be. And so I think that having a community-wide discussion of what we're actually doing here, it would be really important for outlining the kinds of data that we need and the timeliness that we need it and the resolution that we need it at. But in terms of the non-negotiables, I think it has to be electronic. I think it has to be simultaneously delivered to all of the stakeholders who need it. And I think it needs to be cross-sectional. So not just public health, not just medicine, not just laboratories, but all of the above.
Thank you. I'm going to go to you, Eric, on that one, and then finish with Janet on that question.
I'm going to say standardization. Now, what does that have to do with COVID? While COVID reporting is fairly standardized, actually a lot of work has to go into standardizing electronic messages. And the system has reflected the system that we have, and that is by disease agent by disease agent, and everybody wants their chunk. If we're really going to make this work and really be effective, we need to start thinking about standardized data sets, standardized language to transmit this information, even down to standardization of how we upload sequencing data. There's the way we do it in the United States, and there's a way Britain does it, and there's a way Germany does it. And so if we're really going to make some strides, in my opinion, on surveillance and using our ability to move data back and forth effectively for better surveillance, then we have to have this really work hard on standardizing the language necessary to make those things happen. And we have not done that to this point.
Thank you, Eric. Janet?
Thanks, Vivian. I think we have some guiding principles, so I would definitely agree, must be electronic. I think we need to be looking at our approaches from an enterprise level. We need good interoperability between all of our different systems, and that lies in standards, so enterprise, interoperable. And then I also think that it's really critical that we bring healthcare and public health together. So, and I know I've said that before, but to me, that's non-negotiable. I would also say I have said before, I think there are 5 key pillars from a public health surveillance perspective that to me are important for us to really look at how the data is getting delivered across the system so that we can answer questions not just about the most severe infections, which are important, but the continuum of infections. So I believe that we need to invest in our nationally notifiable disease surveillance system, which is starts at the state and local level and delivers data to the federal government, and that's where we get different types of case information. We need electronic case reporting, which is a case report that comes from an EHR into public health with no action by the clinician whatsoever. We need to look at effective delivery of our laboratory data and the laboratory order process. So right now, there might be information sitting in an EHR. When the order is placed at the lab, it doesn't provide the full level of information that public health is going to need when it gets the result. So what's missing on that order? Race, ethnicity. It's missing a huge proportion of the time. We've done a lot to improve getting zip codes and addresses and phone numbers, but we still have major gaps. So laboratory data is functioning as one of the most critical components of the COVID-19 response, and we're still missing 60% of race and ethnicity data on a lab result, and then expecting public health to just be able to know. And so I think we really need to look at that lab order process and ensure that it's collecting the information that public health needs. And that's the lab order process in the private sector, as well as the lab order process for our state public health labs. Our emergency department surveillance, which I think has been talked a little bit about here, is syndromic surveillance, but it's so much more than that now. It's not just looking at chief complaints, but it actually has the diagnosis information in that system, as well as the discharge disposition. And we still have some gaps with emergency departments not online for that. And maybe the data isn't 100% perfect, but it's great for making real-time informed decisions in the heat of an event. And we also really need to invest in our electronic vital records system. And I think those components are the really foundational areas for us to ensure that we're not missing things.
Thank you for all of that good insight. So I'm going to ask one final question before we open it up for both our virtual and in-person audiences to ask their questions to you as a panel. So we've talked a lot today about these high-level frameworks and concepts of things that we need to change as it relates to preparing public health for the next public health emergency or pandemic. I want to talk a little bit more specific now, because when we hear this, it can be a little bit overwhelming. But do you know who or what organizations are making some of the greatest advancements in disease surveillance? What are they doing, and how might we diffuse these approaches, just to make it a little bit more concrete for our audiences here today? Any thoughts would be appreciated. So I'm going to start with, you want to start, Caitlin? Go right ahead.
Sure, I can highlight one innovation that particularly inspires me actually from our UK colleagues. They undertook several surveillance strategies that we haven't implemented widely here in the United States. One was the REACT survey, where they actually mailed out test kits to randomly selected households around the country, asked people to swab their nose, send them back in. And through these regular surveys, they were able to understand in a manner relatively free of bias, in a way that is not true of case reporting, for example, how many people were actively infected. And there were similar studies undertaken for seroprevalence. And I think that particularly as we look ahead to a world where home testing might take up a larger share of our market, not just for COVID, but maybe someday for other diseases as well, supplementing our case-based surveillance system, our more traditional surveillance systems with these kinds of sampling strategies could be really important for helping us to get high quality data that really can flesh out what's happening in our communities.
All right, I'm going to jump to you, Janet, and then Eric.
So I'll just focus in on one thing, and I think the one thing that I really want to focus in on is electronic case reporting, which I mentioned already. There are a number of health departments that have really moved into a new space in terms of engaging with their healthcare community and getting electronic case reports in for COVID, but also for all of the other nearly 100 diseases and conditions that are under public health surveillance. And I really think as we look forward, that is going to be such a critical component. So, for example, in Idaho, they've been able to identify many of their MIS-C cases through electronic case reporting, and those individuals are seen across the border in Utah, and without that infrastructure, they wouldn't be able to do that effectively. So I think as we think about different types of innovation, I also think it's really important that we don't forget the foundation and the core and the data infrastructure that must be built in conjunction with the innovation.
You get the final word, Eric.
You know, I think that from strictly a laboratory standpoint, I think some of the work, as Caitlin referred to in the UK, showed the way in some respects about the use of laboratory testing, both for surveillance purposes, in the midst of the demand for testing for all kinds of purposes. They also outlined, I think, the model that the U.S. is using, I think, effectively for the use of sequencing, and how sequencing is done both as a federal effort and a state effort. I was also impressed with South Korea's approach overall to the pandemic, and while their system allows for it, I mean, they had an integrated approach to both the testing, the identification of cases, and the mitigation strategies. But I think it still comes back to the data and the information systems, and I think Janet captured that as well as I could.
Thank you. So now I want to open it up for our audience to ask questions. If you're here in person, we just ask that you line up at the microphone. And if you have questions virtually, please place your questions in the chat. All right, I'll start here in person.
Hi, John Wiesman with UNC Chapel Hill Gilding School of Global Public Health. Thank you for your comments. I think this is incredibly important conversation. I agree with the pillars. I agree with what we need in terms of data. I guess this is a comment for your potential reaction. I think another essential policy we need is a unique patient identifier that is tied to a demographic database that one can then go into and find out primary language spoken, read, contact information, all the race ethnicity data, so this does not have to be collected over and over and over and put the burden on healthcare providers and others to get this on lab forms, et cetera. So as we talk about all this, part of my dream is that would happen. It would have made life in COVID response much more sort of I don't know about easy, but it certainly would have taken a huge barrier away. So any thoughts or comments you have on that and how realistic that ever could be in our lifetime?
So maybe I'll start, and thank you so much for making that comment, and also for all your service during the pandemic. Really amazing work. Yes, is the answer. We absolutely need that. And I mean, I think, Dr. Khan mentioned in the beginning, a failure of leadership and imagination. We've thought about the need for a national patient identifier for years and years and years, and we still need it. And now is the time for us to galvanize around this and do it. I mean, we will continue to be pained across the public health system for so many things. I mean, for data and information about those impacted by long COVID, which we haven't really talked about today, and yet is going to be a huge issue for disability and burden in our society going forward, for data and information about those impacting all of the diverse set of public health programs. And so I could not agree with you more, and I think that is absolutely a recommendation that we need to act upon.
Thank you. I'm going to take the gentleman here in the gray blazer.
Hello. I would like to ask a question on behalf of Jeffrey Duchin, Health Officer and Chief of the Communicable Disease Epidemiology and Immunization Section for Public Health, Seattle-King County. Long COVID may present a substantial long-term health and economic burden. How are the panel experts thinking about the best way to capture the information we need to understand and address this condition?
Good question there. Who might want to jump in on this one? Eric, Caitlin, any thoughts?
Well, I think it gets back to much of what we've talked about and what Jan mentioned, even to this last question, and that is, how do you collect the appropriate information in a timely manner and be able to move it then within the system? So you've got a patient there, and whether we're talking public health situation or a clinical situation, there's a patient, there's information, and from a public health standpoint, we need a lot more than just billing information, and that's what the private sector depends on. I think it goes back to Janet's point of convening public health and the private healthcare system together and start walking through and talking through some of these points in order to get to the place where we have that patient identifier, whatever form or fashion it is, with important information necessary for public health to do its job in the event of a public health emergency.
And I'll just add, although I don't have a great direct answer to Jeff's question, except to acknowledge the critical importance of such work, I will say that there's an important lesson in there that as we think about the future of public health surveillance, we shouldn't over-index on the COVID experience. Because I think if we do that, then we would not have been prepared to respond for Zika when birth defects were of critical importance. We're not prepared to respond to long COVID. I think we need to take a broad look and make sure that we build in that kind of agility and that broader picture as we think about what we want surveillance to look like.
And I'll just say, thank you, Dr. Duchin, for always asking great questions. And if he were in the room, he could contribute to that answer. I don't think that's just a public health responsibility, though, long COVID. It's really challenging. We haven't well defined it, and it's going to need the research sector and NIH and public health and CMS all coming together. I'm sure I'm leaving out other groups because, I mean, long COVID is something that is going to have tremendous societal impacts. And it's not just how many are there? It is the full spectrum of living with a disability and what we need to do to address that.
All right, thank you for that. Next question, please.
Yeah, Andy Pavia, University of Utah. Thanks for a great session. You hit a lot of important points. I remain a little pessimistic about how the panic neglect cycle is going to undermine these efforts. But I have two questions. One's for Eric and one's for Caitlin and Janet. For Eric, how do we solve the problem of scalability? For the last 3 infectious disease emergencies, CDC and the Laboratory Response Network have not been able to scale up and get diagnostics out quickly enough. Do we have a comprehensive plan that will fix that next time around?
It's been an ongoing effort with our colleagues at CDC to do that, and finally there's some movement on their side that they're truly, with our input, actually, with APHL's input, is looking at ways in which we can do a better job at scaling up, at least for that initial verification, validation of what is emerging. I think the other aspect is, that handoff. In other words, that went from 0 to 60 with COVID. In other words, there was the response in February, and then all of a sudden the push for more testing in the private sector decided to get into it. Zika was a little different. Once we got a test that was reasonably effective, it was some policy decisions that overwhelmed some of the state systems. It wasn't necessarily that we didn't have all that public health was fine, but the private sector was hanging back until policy decisions were made that then a state invited the private sector in. That, I think, is always going to be a little bit of a troublesome issue, but I think we are working with our colleagues at CDC and FDA to determine better ways of getting new tests for emerging threats into the hands both of public health and the commercial sector as needed.
And I think as we've done for genomic surveillance, we have to incorporate all the capacities of academic and reference labs. We
Exactly.
can't depend on the public health sector.
I might just add, when we think about a plan like that, I do think it needs to include academic centers and the private sector, but it's not just about getting a test result. It's how that data flows back into the public health system. And we have a lot of gaps in that space. So even today, samples are sent to CDC. Results don't necessarily make it back to the state health department where the action occurs. The genomic testing that's occurring in the private sector doesn't necessarily flow into the public health system. So I would just encourage us, as we think about the data landscape, it's not just having a piece of data that exists in an individual location, but how that information then has to move back into the public health system.
So my question, next question has to do with kind of what what we'd call the Josiah stamp, village watchman end of the epidemiologic spectrum, getting the actual data from its point of source. And so you mentioned electronic case reporting, which I think is really important. In Utah, we've developed 2 electronic case reports that have worked really well, but we did it in spite of, not because of the EHRs. We had to do a lot of the coding at both the health department and the University of Intermountain. Where are we with getting the EHR companies to participate in this and sort of developing a standardized, scalable way of doing electronic case reporting? And then the other part for Caitlin, which probably keeps you up at night, is how are we going to collect accurate data that allows you to do not just surveillance, but also modeling in the era of at-home testing? And at-home testing is a great advance, but at the same time, it's crippling us. So.
Okay, just before you guys respond, we probably only have less than 5 minutes, so quick responses. Okay. No worries.
So I'll start and I'll say Utah has been at the forefront of doing electronic case reporting and amazing work. I would also say there has been good engagement with the largest electronic health record vendors to really elevate this issue. And I'm excited that there are, we're on the forefront of some incentive payments with CMS to really help improve this. But I think we're still missing certification standards and updated certification standards to really be able to deliver on that. And I do think it is something that ONC, the Office of the National Coordinator for Health IT, is aware of. And I think I'm excited that we have some potential to really bake in some true certification standards.
And for COVID modeling, the case data has gone a bit wobbly as more and more people move to home testing. But we are able to triangulate a little bit with wastewater in places that have wastewater data flowing in. Hospitalizations, of course, continue to be a relatively accurate measure of at least severe disease, although even the relationship of mild disease and severe disease has changed. But one thing I like about modeling is it can take these different data sources and weave them together. But moving beyond this crisis, I do think the future is in random sampling, and I think that's an area that we're looking at closely.
Thank you. I can take one final question, and we'll have very quick responses. Do you have another question, another virtual question? No. Okay. Okay. Go ahead.
Ready to go?
Yeah. Go ahead.
Okay. Hi, my name is Mike. I'm a summer intern at In-Q-Tel and a medical student at Mount Sinai. So thank you so much to the panel for this really informative overview. For my question, I'd like to turn from the domestic case to the global case. And in an era when information environments are becoming increasingly fractured, we're seeing the practical closure of the Russian internet and international institutions fraying. What institutions, technologies, or partnerships do we need to invest in right now to stay ahead of the next pandemic and ensure that we are able to detect upcoming challenges in public health? Thank you.
Excellent question.
Maybe I'll just start by saying that the WHO's new Berlin hub is in part focused on these issues, how to improve not necessarily surveillance specifically, but data and analytics around surveillance issues. They're a brand new organization like us at the Center for Forecasting and Outbreak Analytics. And I think that to the extent your question was who should we invest in, I think that they are really emerging as a key player. Moreover, there are a number of civil society or foundation-led efforts, Wellcome Trust, Rockefeller, that are also beginning to work in these issues. And so I think something of a network is emerging, and I hope that those efforts are successful both individually and collectively.
I would just say that's really complex, and we're struggling even with our domestic response. And so, if this were easy, we would be doing it now already, and it would be done. I think really looking at the international health regulations, though, we need a convening to specifically look at that and identify those key actors and key players. I mean, even when cases are identified now in other countries, even of American citizens, we don't have a good way to gather that information here in the U.S. So I think we probably need a specific convening on that.
Very good. The gentleman here, the final question before I get pulled off the stage here.
It's pretty short, but probably complex. Steve Kutz, represent tribes in Washington State, but I'm also a former elected tribal leader for 20 years, and also work in federal, county, and tribal public health for more than 40 years. And tribes are concerned about data sovereignty. 570-some tribes are concerned about data sovereignty in this conversation. So I don't want to lose track of that. We want to make sure that all the data is collected, but we want to ensure that the sovereignty of our data is protected. So I don't know if you have any comments as we move forward with these plans about that, but and I know that as I sat on the Technical Advisory Committee for the CDC, we talk about that all the time. So thank you.
Excellent comment. Any final comments from our panelists on this before we close?
I mean, I would just say I agree wholeheartedly with you, and I don't think we have ever addressed that well, nor the level of granularity and detail that many of the tribes need to have in order to be able to, fully address the level of issues that are needed. So to me, that's another space where we have a lot of growth, and really appreciate you identifying it, mentioning it here, and lots of work to do.
And I'd just add that because we manage a system in which APHL does oversee the platform that puts through personally identifiable data, and we meet all the FISMA requirements, so that the security, the HIPAA compliance, we don't have the kind of concept of data sovereignty that you're talking about. That has not emerged. And so I think we need to be informed. How do we do that? What is your expectations? What are the tribe's expectations with respect to that? That needs to be informing our process and the means by which the data is being properly addressed, both from a security and a sovereignty point.
So a quick answer is engage with the National Congress of American Indians on that. Thanks.
Thank you. And join me in giving a very warm thanks to our panel here.